Hi, we are on our last topic on endocrine pathology, and today basically we will discuss all diseases involving the adrenal gland. So, adrenal glands are often called as the suprarenal glands because they are located on top of the kidneys. Okay, and each adult adrenal gland weighs from 4 to 6 grams. The right adrenal gland is triangular in shape, just like this picture, while the left is semilunar in shape. If we section the adrenal gland, both of them will reveal a golden yellow cortex and an inner red medulla. Microscopically, each of the glands has two distinct structures. Of course, you have the cortex and the medulla. Now, the adrenal cortex is further divided into three zones, and these three zones also produce steroid hormones. Okay, so these are your zona glomerulosa, which primarily secretes your mineralocorticoids, particularly your aldosterone. And then you have your fasciculata, which secretes your cortisol. And then you have your zona reticularis, which mainly secretes your androgen or your sex steroids. Okay? Now, the adrenal medulla is composed of your chromaffin cells, which synthesize and secrete your catecholamines, no? Mainly your epinephrines. Now, generally, diseases involving the adrenal cortex can be divided into those associated with hyperfunction and those associated with hypofunction. Okay? So there are syndromes relating to hyperfunctioning or adrenal hyperfunction. Of course, this is caused by overproduction of either of those hormones released in the adrenal cortex. So you have Cushing syndrome, which is characterized by an excess of cortisol. You have hyperaldosteronism, which is a result of increase in aldosterone, of course. And then you have your adrenogenital or virilizing syndromes, which are generally caused by excess in your androgen hormones. Okay? And in the medulla, if there is a lesion or a tumor, usually involving increase in secretion of your epinephrine or norepinephrine, or generally catecholamines, then we call that as your pheochromocytoma. So let's begin our discussion on the hyperfunction syndromes that are encountered in the adrenal cortex. Okay, so hyperadrenalism, that's what we call it in general. So number one there is your Cushing syndrome. And as I have mentioned, Cushing syndrome, here there is excess in your glucocorticoids or your cortisol. Okay? Now, this Cushing syndrome can be broadly divided into exogenous or endogenous causes. Of course, vast majority of Cushing syndrome are a result of exogenous administration of steroids. Okay? And we call this as your iatrogenic Cushing syndrome. So in this type, the cortisol is of course increased, and that would send negative feedback up to the higher center in your hypothalamus to decrease production of your CRH, your corticotropin releasing hormone. And this will in turn decrease stimulation in your anterior pituitary gland to decrease also secretion of your ACTH. Now, suppression of ACTH will therefore cause cortical atrophy. Okay? So expect that with your iatrogenic cause of Cushing syndrome. Now, for the endogenous causes, they are divided into two. You have your ACTH dependent and your ACTH independent causes. So they are actually enumerated here in this table. So for ACTH dependent causes, you call this as your Cushing's disease. Okay? So Cushing's disease primarily is a disease involving the pituitary gland. and the hypothalamus. But between the two, it's more of problem involving the pituitary gland. And this is in the form of adenomas. So you have your pituitary microadenoma or pituitary macroadenoma. You also have your corticotroph hyperplasia. Okay, so this is a form of hyperplasia without a tumor in the gland. Okay, now with these conditions, expect that the cortisol is increased primarily because the tumor or disease in the pituitary gland is secreting ACTH. Okay, so ACTH is increased, therefore it will stimulate your adrenal cortex to increase also production of your glucocorticoids or your cortisol, so that both cortisol and your ACTH are increased. So that's true for your endogenous ACTH dependent Cushing's syndrome. And we particularly call this as your Cushing's disease. Okay? So ACTH dependent causes, the most common of that being is your Cushing's disease. Okay, with a relative frequency of 70%, and this is more common in females compared to males. Okay, so what's the appearance of the adrenal gland with your ACTH dependent Cushing's syndrome? So we call this Cushing's disease. Okay, so they will appear nodular, cortical, so there's cortical hyperplasia. So nodular cortical hyperplasia. What about ACTH dependent ectopic ACTH syndrome? So this is less common than your Cushing's disease. Okay, and this may be caused by a small cell carcinoma of the lungs. You have your carcinoid tumor, could also be caused by medullary carcinoma or any of those endocrine tumors. Okay, neuroendocrine tumors that secrete, of course, ACTH. So this is an ectopic type of tumor that is not seen in the pituitary gland but is elaborating or producing ACTH. Okay, so the same thing. The level of ACTH in this condition would be increased and your cortisol will also be increased. Okay? What about ACTH independent causes? Okay, so you have many. Can be adrenal adenoma, which is the most common. Then you have adrenal carcinoma. Generally, for adrenal carcinomas, they are often functioning, no? So that means they really produce cortisol. The adenomas may be non-functioning, but it's worrisome if the patient is symptomatic because this is more associated with a malignant condition rather than a benign condition. Okay? So it can also be caused by macronodular hyperplasia and primary pigmented nodular adrenal disease, okay, which is a condition related to certain mutations. Okay? So here, the cortisol is of course increased, and because of that, it would send negative feedback in the higher center to decrease production of your ACTH. Okay, so your ACTH here is low or decreased, and therefore you expect to see atrophy of the uninvolved portion of the adrenal cortex. Okay, so the gross appearance would depend on the cause. So if it's an adenoma, so expect to see a solitary nodule or tumor in the adrenal gland, whereas the uninvolved portions would be atrophic. Okay? So the lesions of Cushing syndrome in the adrenal gland actually depends on the cause. Okay? So it may show the following abnormalities. It may show cortical atrophy, such as in the case of iatrogenic Cushing syndrome and your ACTH independent Cushing syndrome. So generally here the glands, your adrenal glands, are smaller than usual, similar to the picture on the far right. Okay? And then you can also have a diffuse hyperplasia of the adrenal gland, which we see in your ACTH dependent Cushing syndrome. So here, expect the glands to be markedly increased in size and weight. It can even go up to 30 grams. Okay? So it's similar to that picture on the left. No? So you have a thickened cortex there, diffusely thickened, and may also become nodular. Okay? That cut section at the center of your adrenal gland is the normal appearing adrenal gland. Okay? So you can also have adenoma or carcinoma, which can present with hyperadrenalism. Now, this is a picture of a cross-section of an adrenal gland showing you micronodular hyperplasia. So you have here small nodules composed of 1 to 3 millimeter in thickness, no? And between them, you also see atrophic intervening areas. Okay? So the nodules are darkly pigmented. They appear brown to black here. Okay? And this is due to the lipofuscin or the wear and tear pigment that are admixed with the lipid producing or lipid rich cells in the cortex. So this is the microscopic appearance of the lipid-rich cells that contain your lipofuscin pigment in their cytoplasm. No? So we see them in the right side. Okay. Of course, on the left, that's the common histology of your adrenal cortex, wherein you see those round cells with cleared out cytoplasm or lipid-rich cytoplasm. Another manifestation of your hyperadrenalism, no, in the pituitary gland this time, of whatever cause, so long as there is increase in glucocorticoids, whether endogenous or exogenous in cause, there is this change that we often see amongst the cells in the pituitary gland, and we term this as your Crook-Hyaline change. So in this condition, the granular basophilic cytoplasm of your ACTH producing cells in the anterior pituitary gland often become homogeneously pale. So they have pale cytoplasm instead of basophilic cytoplasm, and they may contain this ropey pink hyaline material or pink material, which is a result of the accumulation of your intermediate keratin filaments. Okay, so they are pointed in the picture. So those are your Crook-Hyaline change. So for the clinical course, the main feature of your Cushing syndrome are enumerated in this table and this illustration on the left. Okay? So all of the symptoms generally develop slowly and can be quite subtle in its early manifestations. And in the early stages of the disorder, this may simply present with hypertension and weight gain. Okay, so these two are the more common early manifestation of Cushing syndrome. Okay, but of course, other manifestations can also be seen, like facial plethora, presence of buffalo humps, rounded face, okay, decreased libido, thinning of the skin, menstrual irregularities, and etc. Now, how do we diagnose Cushing syndrome? So, the laboratory diagnosis of Cushing syndrome is based on the following. Number one would be the 24-hour urine free cortisol concentration, which is increased here. And then we look at the diurnal pattern of cortisol secretion, which is lost in Cushing syndrome. Okay? Now, determining the cause of Cushing syndrome depends on the serum ACTH measurement and of course your cortisol measurement. Okay? And we also measure the urinary steroid excretion after administration of your dexamethasone. So we call this as your dexamethasone suppression test. And generally, there are three patterns of result that we see here. And we relate this pattern on the cause of Cushing syndrome. Okay? Now, so first or initial is we administer a low dose dexamethasone and we evaluate the level of cortisol in the urine. If it's high, then that confirms our diagnosis of Cushing syndrome. Okay? After that, we give another dose of dexamethasone, this time a higher dose of dexamethasone. And after the administration, if the cortisol level in the urine is not suppressed, if it remains elevated, then it can either be because of an ectopic ACTH producing tumor or an adrenal tumor. Okay? Because your pituitary lesions usually are suppressed when you give a high dose of dexamethasone. Okay? So when we talk of pituitary lesions, this speaks of your Cushing's disease as a cause of your Cushing syndrome. Okay? So for ectopic ACTH secreting tumor versus your adrenal tumor, because these two are not suppressed by administration of high dose dexamethasone, we simply look at their ACTH level. Because we know that with an adrenal tumor, though the cortisol level is high, the ACTH level is decreased. Whereas for an ectopic ACTH producing tumor, ACTH will of course be increased. Okay? Okay. Now we move on to another type of hyperadrenalism, this time involving excess aldosterone secretion. So we call this hyperaldosteronism. So this can be primary or secondary to an extraadrenal cause. Okay. So for primary hyperaldosteronism, which is due to an autonomous overproduction of aldosterone, and with that, there will be a resultant suppression of your RAA system and reduction in the plasma renin activity. Okay? So, with this, hypertension becomes the most common manifestation of your primary hyperaldosteronism. And we have three common causes of this. We have first the idiopathic hyperaldosteronism, okay, which is the most common. And then you also have the presence of tumor in the adrenal gland, which is aldosterone producing, which is the second most common cause of primary hyperaldosteronism. And then we have the least and rare type or cause of hyperaldosteronism, which is called as your glucocorticoid remediable hyperaldosteronism. Okay? So for idiopathic, this is often bilateral, meaning it involves both adrenal glands, and there is nodular hyperplasia of both glands. Okay? This accounts for about 60% of cases of primary hyperaldosteronism. Okay, so for the appearance, aside from the hyperplasia, of course, when you say nodular, you should also see their small nodulations. But if you look at them under the microscope, they will simply be composed of those lipid-laden cells resembling your granulosa cells, which are the cells that produce your aldosterone. Okay? Now, for the adrenocortical tumor, well, it can be either a benign tumor, which we call as simply your adenoma, or your carcinoma, or your adrenocortical carcinoma. This accounts for approximately 35% of cases of primary hyperaldosteronism. Now, we call this as your Conn's syndrome. Okay? So, this syndrome occurs most frequently in adult middle life and is more common in women. Okay? And the appearance or gross morphology of the tumor is dependent whether it's a benign tumor. When it's benign, then we see there a solitary encapsulated solid tumor. If it's malignant, well, we see an irregular invasive tumor that may have involved the entire gland. Okay, so it depends on the cause. Okay, now for adenomas, well, the tumor is simply made up of those uniform clear cells with lipid content. Okay? Now, for the glucocorticoid remediable hyperaldosteronism, as I have mentioned, this is an uncommon cause of primary hyperaldosteronism. And this is said to be a familial type of disease that is due to the rearrangement involving this chromosome 8. So with this, the CYP11B2, which is said to be the gene that encodes for aldosterone synthase, is now made under the control of your ACTH. Okay? So this rearrangement now produces hybrid glomerulosa cells that would stimulate the production of aldosterone synthase and will of course produce aldosterone in the presence of ACTH. Okay, so it's under the control now of ACTH. So in that sense, this is also suppressible by your dexamethasone suppression test. Okay. I think I have mentioned that hypertension or elevation of blood pressure is the most common manifestation of any of these causes of your primary hyperaldosteronism. Okay? And that's because aldosterone will cause sodium reabsorption from the tubular lumen. Okay, so it's thrown back to the blood together with water, so water is retained, therefore blood volume will be expanded. So that contributes to your blood pressure elevation and your hypertension. Okay? So how do we diagnose primary hyperaldosteronism? So one is, of course, there's elevation of your aldosterone levels, and we can also confirm that by doing a ratio between your plasma aldosterone concentration and your plasma renin activity, which is elevated with your primary hyperaldosteronism. Another way is to do aldosterone suppression test, wherein here we administer high loads of sodium or salt, and then we check on the aldosterone in the urine. Okay, so normally after a loading dose of sodium, aldosterone should be suppressed. But if it's not suppressed, then that confirms our diagnosis of primary hyperaldosteronism. Okay. So for the therapy, well, it depends on the cause. For adenomas, it's amenable through surgical excision. In contrast, surgical intervention is not very beneficial in those with bilateral hyperplasia or those with familial cause of primary hyperaldosteronism. Okay? So for bilateral hyperplasia, we can do medical management by giving spironolactone. Now, we also have secondary causes of hyperaldosteronism such as decreased in renal perfusion from, let's say, arteriolar nephrosclerosis or renal artery stenosis, or you have your hypovolemia and edema, for example, in patients with congestive heart failure, nephrotic syndrome or cirrhosis, and pregnancy. Okay, so these are secondary causes of increase in aldosterone level because of the activation of your RAA system. So here, your plasma renin is of course elevated. Your aldosterone is also elevated. Okay. Now we move on to the last type of hyperadrenalism. This time, here we encounter increase in androgen levels. Okay. So this will result in disorders of sexual differentiation such as virilization or feminization. Okay? And there are many causes to this. One would be your primary gonadal disorders, and of course you have your primary adrenal disorders. For adrenal causes, it can either be excess due to adrenocortical tumors or your congenital adrenal hyperplasia. In fact, congenital adrenal hyperplasia is the most common cause of ambiguous genitalia in newborn. Okay? So this is an autosomal recessive disorder wherein there is an enzymatic defect in the biosynthesis of cortisol from cholesterol. So here there is decrease in cortisol level and resultant increase in the ACTH level. So we have different types of congenital adrenal hyperplasia depending on the enzyme that is deficient. So we have 21 hydroxylase deficiency, which involves mutation in this protein called CYP21A2. By far, this is the most common, accounting for over 90% of cases of congenital hyperplasia. So here, the deficiency, your 21 hydroxylase, would block the conversion of the progesterone to 11-deoxycorticosterone, okay, and 17-hydroxyprogesterone to 11-deoxycortisol, which would lead to the decreased synthesis of your aldosterone and cortisol respectively. Now, this failure of conversion will lead to steroid precursor buildup behind the defective step, and this will channel, okay, into the other pathways, resulting in the increased production now of your androgens. This accounts for the symptom of your virilization. Okay, so there will be increase in sex steroid hormones, primarily your testosterone. So there are three distinctive syndromes of your 21 hydroxylase deficiency. You have your classic type or your salt wasting adrenogenitalism. You have your simple virilizing adrenogenitalism and your non-classic adrenogenitalism. Now for salt wasting syndrome, the deficiency both in mineralocorticoid and glucocorticoid is manifested early at birth. So this will result in salt wasting, hyponatremia, and hyperkalemia, which will also cause acidosis, hypotension, cardiovascular collapse, and possibly death in infants. So this is the most serious form of congenital adrenal hyperplasia. Okay? And aside from that, of course, there's virilization, which is manifested by clitoral enlargement and labioscrotal fusion. Now, your simple virilizing adrenogenital syndrome is presented without salt wasting. So the main manifestation here is presence of genital ambiguity, or sometimes we refer this to as pseudohermaphroditism. Okay? So it accounts for approximately a third of patients with 21 hydroxylase deficiency. So here, there is sufficient mineralocorticoids, so salt wasting crisis is prevented. However, there is still lowered glucocorticoid levels that will cause feedback inhibition of ACTH secretion. Okay, and there is also increased level of testosterone. Okay, thus the resultant virilization. So it can be manifested as fused labia, enlarged clitoris, or presence of urogenital sinus. The non-classic or late onset adrenal virilism is significantly more common than the classic patterns mentioned previously. No? There is here a partial deficiency only of your 21 hydroxylase function, which accounts for the later onset of disease. And usually individuals are asymptomatic and would present with mild manifestations such as hirsutism, acne, and menstrual irregularity, which are often manifested during puberty. Okay? So for the morphology of congenital adrenal hyperplasia, now oftentimes the adrenal gland may be hyperplastic, okay, where the cortex is thickened or maybe nodular. And if you look under the microscope, the nodularities will be composed of compact eosinophilic to lipid depleted cells intermixed with lipid-laden clear cells. Okay? And there may also be adrenomedullary dysplasia. So this adrenomedullary dysplasia is characterized by incomplete migration of chromaffin cells to the center of the gland in the medulla. So they are seen intermingling with your cortical cells in the periphery of the cortex. Okay, now we move on to the opposite of hyperadrenalism, which is your adrenal insufficiency. Okay, now we have three general categories of adrenal or adrenocortical insufficiency. You have your primary acute, which is also called as your adrenal crisis. And then you have your primary chronic, which is also called as your Addison's disease, and the secondary causes of adrenocortical insufficiency. Okay? So for primary causes, we have this table separating acute and chronic settings where we see them. So for acute, commonly this is encountered in the following scenarios: in Waterhouse-Friderichsen syndrome, in those who had sudden withdrawal of this long-term corticosteroid therapy, and in patients who have acute stress with an underlying chronic adrenal insufficiency. Now for chronic, the common clinical settings where we see adrenal insufficiency would be in autoimmune adrenalitis, which accounts for 60 to 70 cases and is by far the most common cause of primary adrenal insufficiency in developed countries. Okay, so we have two autoimmune polyendocrine syndromes under this. You have your APS1 and APS2. Okay, so kindly read more on these two types of your autoimmune adrenalitis. Okay, now we also have more common in our country would be due to tuberculosis. Then you have AIDS and metastatic conditions. Okay, but there are other causes of chronic adrenal insufficiencies like systemic amyloidosis, fungal infection, sarcoidosis, and hemochromatosis, but they are less common than those for mentioned. Okay, so this is an example of acute adrenocortical insufficiency in a child who develops sepsis and disseminated intravascular coagulopathy. So if you notice, there are marked purpuric lesions all over the body, okay, of this infant. So we call this syndrome as Water-Friderichsen syndrome. It's an uncommon but catastrophic syndrome which is characterized by overwhelming bacterial infection, classically your Neisseria meningitidis septicemia, but occasionally it can also be caused by other virulent organisms. Okay? And you also have here progressive hypotension leading to shock. And all of these manifestations are due to the rapidly developing adrenocortical insufficiency associated with massive bilateral adrenal hemorrhage. Okay? So if we look at the adrenal gland, both glands will show marked hemorrhagic necrosis similar to what we see here in the picture. Now for primary chronic adrenocortical insufficiency, as I have mentioned, most of cases are attributed to either one of these four disorders, no? Your autoimmune adrenalitis, your tuberculosis, your AIDS, and metastatic disease. So this would, of course, result to failure to produce your glucocorticoid, mineralocorticoid, and androgen. And generally, patients with primary chronic adrenocortical insufficiency are asymptomatic until 90% of the cortex is destroyed. Okay? So for the microscopic appearance, it would depend on the cause. If it's autoimmune adrenalitis, being autoimmune in its nature, then expect to see lymphocytic infiltrates in the cortex and even in the medulla. Okay? So if it's TB or fungal disease, then the adrenal architecture will be effaced by granulomatous type of inflammation. Okay? So for metastatic lesion, of course, you will see there the metastatic tumor. And generally, patients with this condition present with weakness. Sometimes you may see hyperpigmentation, hypotension, anorexia or weight loss, and vomiting or any of those GI symptoms. The treatment for this is administration of your corticosteroid. Now, there are also many causes of secondary adrenocortical deficiency, and it's mainly due to destruction of the pituitary gland. No? So, either in the presence of tumor there or following surgical intervention for a primary tumor in the pituitary gland, radiation therapy, or trauma to the gland. Okay? So, with this, expect that the ACTH level is decreased, so as with your cortisol and your androgen. The aldosterone level are often normal in this case, and as opposed to your primary adrenocortical deficiency, here in secondary, patients will not present with hyperpigmentation. Now let's go to tumors. Now there are different tumors that we may encounter in the adrenal gland. Okay, and for these tumors, we further differentiate them into whether they are functional or non-functional. But most adrenocortical adenomas are non-functional or are clinically silent, and they are usually incidental findings at autopsy or during abdominal imaging for an unrelated cause. Morphologically, we cannot distinguish functional from non-functional adrenocortical tumors. The functionality is actually based on the clinical evaluation and measurement of hormones in the blood. But for functional adenomas, which is more commonly associated with hyperaldosteronism and Cushing syndrome, okay? And of course, when we say adenoma, this is a well encapsulated solid tumor. Now, when the tumor presents with virilizing symptoms, it's more likely to be malignant or your carcinoma. So, for functional adenomas, since they produce steroids, then they would send negative feedback to the pituitary gland not to produce ACTH anymore. And therefore, the adjacent tissue in the adrenal gland would be atrophic. For non-functional adenomas, the adjacent cortical tissue would still be normal. Okay? So microscopically, adenomas are simply composed of cells similar to those populating the normal adrenal cortex. So this is a typical cortical adenoma which is well circumscribed. Okay? So the tumor could be very big, no, it's and very heavy, and the cross section usually appears yellow to yellow brown. Okay? And that's because of the presence of lipids. Usually, when you think of lipids or fats, they will appear yellow in color. And of course, microscopically, you will see here cells that have abundant cleared out cytoplasm because of the lipid content. Sometimes you may see pleomorphism, no, even if it's benign, and we call that as endocrine atypia, and that's still considered as benign. The malignant counterpart is called as your adrenocortical carcinoma. And as I have mentioned, more often than not, this tumor will present with symptoms. So they are functional. And the tumor is very heavy and very bulky, and it can even weigh up to more than 100 grams. Okay? Some of the tumors may be encapsulated and will show areas of hemorrhage and necrosis. So if you cut it across, you will note the softness of its consistency. Although it's solid, but it's soft. Okay, and that's because of the necrosis and hemorrhage. So it has variegated appearance, meaning it may come in different color. There's an area where it's pink, there's area where there's or where it's red or brown. Okay, so the color is very different. Okay, so we call that variegated appearance. And microscopically, you will see atypia ranging from mild to marked, and you will of course see increase in mitotic activity, and it's very common also to see their bizarre mitotic figures. Okay? Now, the tumor may metastasize via hematogenous or lymphatic route. So this is how your adrenocortical carcinoma would look like. So it will really appear bulky, and it sits on top of the kidney. Okay, and the cut section will show you areas of necrosis and hemorrhage and even cystic change. Now, adrenal cancers have a strong tendency to invade the adrenal vein, the vena cava, and lymphatics. Okay? And metastasis is also very common to the regional and periaortic lymph nodes. Microscopically, this tumor may be composed of cells resembling those cells seen in the cortical adenoma. Okay, so they may be lipidized cells. Okay, but of course, it's also common to see pleomorphism. You see a lot of nuclei that are hyperchromatic and enlarged, and you may also see bizarre, monstrous giant cells there, similar to what we see in the picture on the right. Okay? Alright. Now we're done with all the lesions involving the adrenal cortex. We move on to the lesions involving the adrenal medulla this time. So when you say adrenal medulla, this is the area at the center of the adrenal gland. And this is mainly composed of two cells. Your neuroendocrine cells, which we termed as your chromaffin cells, and the cells supporting the chromaffin cells, which we call as your sustentacular cells. Okay? And the adrenal medulla is a major source of your catecholamines, like your epinephrine and your norepinephrine. And the most important disease involving the adrenal gland are your tumors. So you have tumors of chromaffin origin or your neuroendocrine origin, so we call this as your pheochromocytomas, and you also have tumors of neuronal origin, your neuroblastomas. Okay, now we will not discuss neuroblastomas anymore because this was already discussed with you previously. So pheochromocytoma is again a tumor composed of chromaffin cells, and they synthesize and release catecholamines. Now, the dominant clinical manifestation of pheochromocytoma is of course hypertension. And this is common in women compared to men. And the other features of pheochromocytoma is traditionally summarized by this rule of 10. So what is this rule of 10? One would be that 10% of pheochromocytomas are extra-adrenal in location, meaning there's 10% of them seen outside the adrenal gland. Okay? Examples would be in the carotid body or in the extra-adrenal paraganglia. Okay? And we designate that as paraganglioma. Okay? Another rule of 10 is that 10% of them are bilateral, and we encounter them usually in sporadic tumors. Okay? So bilateral meaning both adrenal glands are involved. Okay? And then there's another 10% that the pheochromocytoma may turn out to be biologically malignant. And this is defined by the presence of metastatic disease. Okay? And then there's another 10% here that is not associated clinically with hypertension. And there's another one, but it's not according to the rule of 10 anymore. You see, there's 25% of this tumor that will harbor this germline mutation in one of the 6 known genes. Example of this include your RET, your NF1, and your SDH. Okay? Now, patients with these germline mutations are typically younger at presentation than those with sporadic tumors and more often harbor a bilateral type of disease. Now, this is how your pheochromocytomas would look like grossly. So, they may be small, but in this picture, it looks very big. Okay, and it's circumscribed, and it may show areas of hemorrhage, necrosis, and even cystic degeneration. Okay. Microscopically, what you will see would be clusters of these polygonal cells, sometimes spindle-shaped cells, surrounded by your supporting cells, or your supratentacular cells, which may appear spindly in structure. Okay? So these cells are grouped into nests or alveoli pattern, which we call as your Zellballen pattern. Okay? So they look like clusters, ball clusters made up of these polygonal cells with round nuclei and stippled chromatin pattern. Okay? Now, the salt and pepper chromatin pattern or the stippled chromatin pattern is very characteristic that is shared between many neuroendocrine tumors and is also seen here in pheochromocytoma. Okay? Now, for the laboratory diagnosis of pheochromocytoma, this is based on the demonstration of your increased urinary excretion of your free catecholamines and their metabolites, such as your vanillyl mandelic acid and metanephrines. Okay? Isolated benign pheochromocytomas may be treated surgically. Okay? You can also give adrenergic blocking agents to suppress the symptom of hypertension. Okay, now we move on to MEN syndrome. MEN stands for multiple endocrine neoplasia syndrome. Okay, now this is a group of inherited diseases resulting in proliferative lesions of multiple endocrine organs. So this may be in the form of hyperplasias, adenomas, or carcinomas. Now, these tumors occur at a younger age than your sporadic tumors. They may arise in multiple endocrine organs either synchronously, meaning at the same time, or metachronously at different times. Even if they are seen in one organ alone, the tumor may often be multifocal or may show multiple lesions in one organ. Okay? And the tumors are usually preceded by an asymptomatic stage of hyperplasia involving the cell of origin. For example, in MEN2 syndrome, when the thyroid gland is involved, particularly um, involving your parafollicular cells, initially there may be parafollicular cell hyperplasia in the thyroid parenchyma, and this may be followed by the development of your medullary thyroid carcinomas. Okay, so it initially presents with hyperplasia before the tumors may be formed. And the tumors here are usually more aggressive than your sporadic endocrine tumors, and they recur in a higher proportion than your sporadic tumors do. Now, MEN syndrome is divided into MEN1 and MEN2. So MEN1 is also called as your Wermer syndrome. So this is a rare heritable disorder with a prevalence of 1 per 100,000. So MEN1 is characterized by abnormalities involving the 3Ps, your parathyroid, your pancreas, and pituitary gland. Okay? Now, primary hyperparathyroidism is said to be the most common manifestation of MEN1, which is seen in 80 to 95% of patients and is the initial manifestation of the disorder in most patients. Okay? So, parathyroid abnormalities may include both hyperplasias and adenomas. Okay? Now, for the pancreas, endocrine tumor of the pancreas are said to be the leading cause of morbidity and mortality. And the pancreatic tumors are usually very aggressive and malignant and often seen with metastatic lesions. Okay? Now, for the pituitary gland, the most frequent anterior pituitary tumor encountered in MEN1 is your prolactinoma. Now, there is a genetic mutation, it's a germline mutation that is seen in MEN1, and that is your tumor suppressor gene. We call as, it's a gene that encodes for this protein we call as menin. So, it's called as MEN1 gene. Okay, so it's a tumor suppressor gene. For MEN2, this is further subclassified into three distinct syndromes. You have your MEN2A, MEN2B, and the familial medullary thyroid carcinoma. Okay? So MEN2A is called your Sippel syndrome, and this is characterized by pheochromocytomas, medullary carcinoma of the thyroid gland, and parathyroid hyperplasia. Okay? Medullary carcinomas of the thyroid occur in almost 100% of patients with MEN2A. Okay? Now for MEN2B, Patients usually develop medullary thyroid carcinomas, which are usually multifocal and more aggressive than men 2A, and pheochromocytomas. Okay? But unlike men 2A, here in men 2B, there is no primary hyperparathyroidism. But instead, here in men 2B, it is usually accompanied by neuromas and your ganglioneuromas, which may be seen on the skin, on the oral mucosa, in the eyes, in the respiratory tract, and even in the gastrointestinal tract. Sometimes the patient may also present with Marfanoid habitus, wherein you have long eggshell skeletal features and hyperextensible joints. Okay? And the last subclassification under your MEN2 is called your familial medullary thyroid carcinoma. So this is a variant of MEN2A with strong predisposition to medullary thyroid carcinoma. And no other clinical manifestations are associated with this. Okay? So with this, I end my lecture. Thank you so much for listening.